everybody, and welcome to tonight's Research Tuesdays. And the forum this evening, as you know, is Men's Health. I'd like to start by acknowledging the Kaurna people, the original custodians of the Adelaide Plains, and the land on which the university's campuses here at North Terrace, at Waite, Theberton and Roseworthy are built. So I'm Alistair Burt. I'm the Executive Dean of the Faculty of Health and Medical Sciences, and it's a great privilege to welcome you this evening and to introduce the speakers. But I'd like to also say right up front, apologies for the delay in getting into the theatre this evening. There seems to be some timetabling issue, which I'll take up with the central authorities. So I can only be grateful that we didn't get a repeat of Sunday's weather front and that you remained dry, but apologies nonetheless. So tonight we turn our attention, as I've said, to men's health. And this year is the 10th anniversary of the research partnership between the university and the Freemasons Foundation, the charitable arm of Freemasonry in South Australia and Northern Territory. The Freemasons Foundation Centre for Men's Health is the product of this unique partnership, a centre which is committed to improving the health and well-being of men. This 10-year partnership and $3 million investment by the Foundation has resulted in the training of 16 research fellows and more than 60 students. It has advanced our understanding of and clinical practice relating to prostate cancer, urological and reproductive health, cardiovascular disease and diabetes, anxiety and depression, cancer screening and healthy lifestyle, and healthy aging. And the centre has remarkably produced over 250 peer-reviewed scientific papers in some of the leading journals of health and medicine over the past decade. And it's contributed to federal and state government health briefings and participated in standing committees and inquiries relevant to men's health, and very, very much more. So tonight we hear from members of the Freemasons Foundation Centre for Men's Health. And to introduce them, I'd like to welcome another member of that centre, Professor Deb Turnbull, who holds a chair of psychology in the university.
Good evening, everyone, and thanks for coming out on this cold night. I am a member of the Freemasons Foundation Centre for Men's Health Research Advisory Board, and I'm one of the people who work alongside other researchers and students in that context. As our Executive Dean said, we've got two excellent speakers for you tonight. We've got Professor Robert Adams and also Dr. Shawn Martin. Gary Whittet sends his apologies. He's en route from the United States and has got caught up in that context. So our plan tonight is you're going to hear from our speakers, and then it's going to be my job to convene a panel where we'll get a chance, all of us, to pose as many tricky questions as we wish. So what I'd like to do is first introduce you thoroughly to our first speaker, Professor Robert Adams. Bob is a very interesting person because he is a physician. He is a senior respiratory and general physician at the Queen Elizabeth Hospital, and he's also a key member of academic staff within our discipline of medicine. But in addition to his clinical roles, he's a very active researcher. So he directs the Basil Hetzel Research Institute's Health Observatory at the Queen Elizabeth Hospital that some of you will be familiar with. And he also chairs a very interesting alliance, which is to do with health literacy. This is really important because we know health literacy is vitally linked with health outcomes. So, welcome, Bob.
Thank you, Deb. Clearly I'm not Professor Whittet, so for those of you who've come specifically to listen to him, my apologies. For those of you who know Professor Whittet, hold the tomatoes until later because that's not me. We're going to talk about men's health, which, to use a definition based on the British Health Development Agency, encompasses the conditions that are unique to men or more prevalent in men, and for whom particular risk factors exist and contextual factors exist, and for whom responses need to be developed in a particular way specific to these problems. The one message of this talk really can be encapsulated on this slide, which is that men behave differently, particularly to women, not badly, and that health services need to recognise this fact and respond accordingly. What I'm going to talk about, or what Professor Widdett was going to talk about, and I'm going to talk about for you, is part of the issues around male health and the relative problems that men have relative to women. The myths around men behaving badly, it might be a good TV show, but it doesn't necessarily tell you a lot about the reality of the world. And to suggest some of the solutions that a health service can make to address some of these issues, particularly around a couple of problems that we will talk about in a minute regarding sleep problems and lower urinary tract problems. Okay. Male health disadvantage. There are problems that are specific to men that are an issue. The suicide rate in Australia is alarmingly high, and is alarmingly high in men from a very early age and persists throughout life. Diabetes, a common and increasingly common illness, tends to occur around 10 years earlier in men than women. The issue there, of course, is that complications and significant health problems that relate to diabetes are largely a problem of the amount of time, the longevity you have of the disease. So if you get it earlier, you tend to get more of the significant health problems related to heart disease, blindness, and peripheral vascular disease. Hospital separations in children are more common in boys than girls. During the reproductive years, women are more commonly admitted to hospital. And then as chronic disease takes over, again, men are overrepresented in the amount of times they go to hospital. And when they go to hospital, there are a large range of problems. One of the examples given here is hip fracture, a very common problem in elderly people. The mortality rate of that is alarmingly and significantly high, but twice as high in men as it is in women. This has significant indirect consequences to the economy, both individually and to society. Retirement due to sickness or disability is very high in Australia. We tend to retire earlier than other countries. The proportion of the population employed over the age of 65 in New Zealand is around 30 to 35%. In Australia, it's about 15 to 20. Part of that, and a significant proportion of that, relates to retirement early due to sickness and disability, and that tends to be much higher in men than women. And it also relates to how often and how much of a problem there is going to work when we are capable of working. Absenteeism from chronic diseases tends to be more of a problem in men as the number of chronic diseases goes up. So one of the things we like to talk about is the myths around health service use and men. One is that men are neglectful of their health. The second, men don't go to the doctor. The third, when they get there, they don't speak. There's a series of grunts that occur and nothing much else happens. And finally, that the problem of all of this is related to the notion of masculinity. Okay. Men tend to self-monitor and tend to take action based on that self-monitoring, based on previous experience, based on their knowledge and health literacy. And whilst that clearly relates to education, it's not quite the same thing. And in fact, there can be less well-educated people with remarkably high health literacy and correspondingly less health literacy related to relatively high education. And at one point we did a survey in this in South Australia and found at least 20% of people with a university degree had poor health literacy, which as some people suggested may be related to the quality of the university education. There's also clear actions related to how they perceive their illness, the priorities that they have in life, and importantly, one of the things that we suggest access to and the nature of the available service to them. And it's important to bear this in mind. Men are not generally neglectful of their health. Most men, 80 to 90%, depending on which survey you look at, have been to the GP at least once in the last 12 months, and that's all adult men, ranging 18 to wherever. And also, if you ask them, are they worried about their health or motivated to improvement? Again, the vast majority describe themselves as being interested in their health and motivated to make improvements. So health is a big issue to men. It is not something that is pushed to the background. However, the main reason for going to the GP tends to be acute problems. There's an acute health crisis, you need medication, with other things being less common. The consults, on average, tend to be shorter, and if your average GP consult is 10 minutes, 2 minutes is about 20% less. So it's a significant difference in the amount of time spent in a consultation. And part of that relates to the fact that attention to other health concerns other than the main issue that you go for tends to not be done, more so in men than it is in women. So the message of this slide is that on average there are less GP visits for preventive health or screening, and that at those GP visits less attention is paid to something else rather than the primary concern for which someone has gone to. Men do have, on average, at the same level of education, poorer health literacy than women, and disorders tend to present in gendered ways. An example here is that of depression, where the majority of men who have significant mood disorders and significant depressed mood do not receive a clinical diagnosis of depression over a 5-year period, and that tends to be despite the fact that depressed men go to the GP more often than women with similar sorts of problems. Okay. It has been suggested that the issue here is masculinity, and I'd suggest some of the things that are noted here around independence and self-sufficiency, in fact may relate more to men's perception of their roles in life and the efficacy of their roles, particularly things like their role as a partner, their role as a father, as a provider in the workplace, and that things such as physical strength and independence and self-sufficiency may be more of a external manifestation of the internal need to fulfil those roles, most of which is related to the notion of maintaining independence. And if we concede that that is the most important thing, then clearly it goes to the notion of treating men the same as women during a consultation may in fact be part of the health system's problem and may be contributing to some of these health disadvantages that we noticed in the first slide. Secondly, if that's how we approach this problem, then men will talk about their health, but it needs to be in the right context and approach the way they want. Men tend to, and this is research done through the Freemason Centre, want, or say they want, a frank approach to questions. So we tend to teach medical students about open-ended questions and letting people speak. Men, as a rule, as a group, often want far more directed questions at a directed problem. And that's because they're very interested in directing themselves towards a solution to that problem. Perhaps more than some of the other issues that might get brought up. And humour is very important. A lot of male interaction tends to be around teasing and humour, and men at least will say that humour in a consultation is also an excellent way of bringing out how they interact. And that the consultation wants to be directed towards resolution and a solution. So, what can we do, or what might the health service respond to some of these issues that we've raised? So, overall, the idea is perhaps to design health services to accommodate the needs and preferences of men. The health service is not perhaps overly well designed to accommodate the preferences of any of its patients, and one might say as a general rule, health services tend to be designed to satisfy the practitioners, with the patients being the thing that get acted upon. That has problems for either gender. But it needs to be thought of that there probably are differences in the way men and women might interact with a healthcare service. The way we treat and train practitioners to communicate with men may need adjustment, in that if we acknowledge things like the goals of men are directed towards solutions, the goals of men are directed towards responsibility, problem solving, self-management, then the communication styles will tend to be a little bit different. Men tend to still work 9 to 5 work hours, and clinics that are designed to also work 9 to 5 can be very inconvenient. Employment tends to not necessarily be sympathetic towards leaving to go to see a doctor. And again, that can be something that we might need to talk about. And I'll be talking about later on the notion of promoting interest of employers and the community towards health, particularly with regards to sleep. Preference can be addressed towards the notion of self-monitoring and facilitating self-management, which involves improving and focusing on health literacy as a means of health communication, around e-health and evidence-based websites that provide information in a way that men can look up and then find things out. And finally, we propose a focus on looking for and actively screening for things that are important, that are harbingers and concerns of other major diseases. And some of the examples we're going to talk about today that we think are really important are sleep problems, because they affect people's lives, they're easy to see, nocturia, getting up at night to go to the toilet, and erectile dysfunction, all of which are important issues which are often minimised or people don't want to talk about, but in fact are closely related to other significant and important health conditions such as cardiovascular disease, diabetes, and mental health problems. And so, to summarise all of that, we think that, back to the first slide, men tend to behave differently. The health system needs to take that into account, and we think there are a number of ways we can do that without revolutionising or completely redesigning our problem, but with a slightly different mindset. Okay, now there was going to be a break, but you've got me for the whole time. So, I'm going to talk to you about sleep and some other things. For my talk, what I'd like to say is this is Cristiano Ronaldo, the highest paid, or at least until last week, the highest paid footballer in the world, and arguably the best footballer in the world, who plays for Real Madrid and Portugal. Cristiano Ronaldo has a sleep coach, full-time, on a probably higher salary than all of us put together. And if there's one thing I want to take away from this talk regarding sleep is that the person who's the best footballer in the world thinks it's important enough to add sleep to his regimen and to his entourage in order to continue to be the best footballer in the world, along with all the other things that he goes with. And one of the reasons you might think about that is there's an awful lot going on when you're asleep. And this slide just goes through all of those. Some of the things that are important to recognise in terms of a professional sportsman is that most of your muscle recovery and most of your recovery from injury occurs while you're asleep. So all sporting teams will talk about doing recovery sessions at the beach, nowhere near as important as getting their 8 hours of sleep in terms of maintaining their recovery. If you're more cerebrally inclined, again, the most important thing you can do as a function of sleep, particularly REM sleep, is to get enough of it, because a lot of the sort of, mental waste product we produce tends to be cleansed while we're asleep. And we know poor sleep is significantly associated with problems with cognition and cognitive issues. So there's a lot going on when we're asleep. Therefore, do we get enough of it? This is a survey we did last year of 1,100 people around the country, and the simple message from this is, no, we don't. Around 50% of the population, male or female, says they don't get adequate sleep, and that might be difficulties falling asleep, difficulties staying asleep, difficulty waking up, difficulty feeling refreshed. Things like snoring and symptoms of things like obstructive sleep apnea are very common. And a lot of people describe daytime symptoms, be that fatigue, irritability, outright sleepiness, falling asleep. A third of the population describes that. Interestingly, the grouping of the population that gets that the most are actually those aged between 18 and 44. It's young people who have really lousy sleep and feel it. What I'd like to point out, though, is down the bottom there is a couple of things that we'll talk about later on. Sleep apnea is 4 times more common, diagnosed at least, in men rather than women, and insomnia symptoms tend to be slightly commoner in women than men. Sleep problems are expensive. There's the direct costs of the problem, but there is a huge indirect cost burden related to reduced productivity and also disability adjusted life years. And the figure there from a few years ago is around $36 billion. What sort of thing leads to that? This is part of this survey as well. And it says that around a quarter of the population have reporting taking time off work in the previous 3 months from sickness because of problems related to their sleep. Now, some of that relates to clinical diagnosed conditions such as sleep apnea or insomnia, but even if you take those people out of the equation, people without a diagnosed condition are 3 to 4 times more likely to not go to work because of illness due to a sleep problem. Okay. These are data from a male study. It was done through the Freemason Centre with support from the NHMRC and the ResMed Foundation and other groups. And what we were interested in looking at was some of the other things that contribute to cardiovascular and cardiometabolic diseases, and we thought sleep might be an important problem there. And we found that undiagnosed sleep apnea, where you stop breathing at night a significant time, and that leads to problems with reduced oxygenation and reduced breathing and other problems that we'll talk about in a minute, is remarkably common in men. At least half of this population aged over 40 had undiagnosed sleep apnea, and 12% of them had undiagnosed severe sleep apnea. And if you think that's by a sample or remarkably unusual, it's actually very similar to data that has been obtained in Switzerland and Brazil as well. Okay. It tends to go up with 2 of the scourges of the modern era, being age, we're getting older, and BMI. And so you can see that the older age group who have a higher BMI have a remarkably high prevalence of undiagnosed moderate to severe sleep apnea. Is that a problem? Yeah, we think so. Here's data from a Spanish group that followed people up with untreated sleep apnea over up to 12 years. And the top graph is people who had fatal cardiac events. The bottom one is non-fatal cardiac events. And the red graph, the one leading up, way up ahead of the others, is severe sleep apnea. And you can see that there's about 3 or 4 times greater risk of dying and also having non-significant, non-fatal heart attacks if you've got severe untreated sleep apnea. Those of them that got treated, down the bottom here, we're about the same as, I got carried away, about the same as people who didn't have sleep apnea. Why might that be so? Complicated slide, I won't talk you through all of it. What you do when you stop breathing is your oxygen goes down and you put a lot of strain on the rest of your body, and that leads to increases in inflammation, it leads to increases in oxidative stress, it leads to increases in your blood pressure, and that contributes to all of the things we've got down the bottom here, which is increased risk of cancer, increased risk of stroke and hypertension, increased risk of metabolic problems related to diabetes, and problems related to cognition. And it's not because it makes you sleepy. Most people with sleep apnea are not in fact sleepy. But what they do have is quality of life reductions independent of that sleepiness. And the level of that quality of life reduction is about the same as you get with heart failure and many cancers. It's a significant problem for people. And it also tends to increase your risk of being depressed. I talked about here the notion earlier on of wanting to think about sleep because it relates to more significant diseases, and this slide details some of what we found when we examined this in our cohort, which shows that sleep apnea is associated with an increased risk of elevated blood pressure, an elevated risk of diabetes and poor control of diabetes if you have diabetes, an elevated risk of chronic kidney disease, and Shawn is going to talk about later on some of the problems related to nocturia and erectile dysfunction as well. To go into another issue, that of insomnia, which is a 2-step problem. Insomnia is actually problems with sleeping, either getting off to sleep or staying asleep, with some sort of daytime consequences and daytime symptoms. And you recall that 17% of men report significant problems like that. and over 40% have 2 or more sorts of sleep problems. This is a graph that shows, despite that, relatively few general practice consultations are for insomnia. 20% of the population have got it, and 1.5% of GP consultations relate to insomnia. When people get to the GP for their insomnia, they are managed in certain ways. The top graph here is that 90% of people who would describe insomnia get given sleeping tablets. About 20% of them get given some sort of counselling around adjusting their sleep, and a minuscule proportion are referred for psychologist input around their sleep. That's despite the fact that certainly the evidence shows and modern guidelines suggest that the way to manage insomnia is around cognitive therapy and adjustments to the way one approaches sleep, and that sleeping tablets are both largely ineffective, potentially dangerous, expensive, and are not certainly the first thing line treatment. The other point is that insomnia tends to be very commonly associated with sleep apnea. So the number of people who are presenting with difficulties getting off to sleep, in fact, are difficult getting off to sleep because they can't breathe. And these group of people are far greater risk of getting things like depression. The health literacy issue is important because we've shown that people with lower health literacy are much less likely to be diagnosed with sleep apnea but have the problems. So, ultimately, sleep, as we've identified, is a significant problem. It's related to significant health issues, and it is a common problem in our society. As a society, we tend not to value sleep or prioritise it. And the title of the movie here would probably sum up, as a general rule, how the majority of the population tends to respond to sleep problems. It is not seen in the same light as things like diet, exercise, smoking as crucial to health and well-being, but in a male health context, it is certainly something that is a problem. It's something that can be addressed, and is something that might be a good way to getting into discussions around these other things that doesn't involve quite the emotive or pejorative aspects that might be related to you're overweight, you don't do enough exercise, and you're a bad person. It also talks to gendered perceptions. One of the slides I showed earlier showed that diagnosed sleep apnea is 4 times commoner in men than women. We don't think that's the reality, and we think actually sleep apnea is much commoner in women than has been reported, and is probably almost as common in women as it is in men. But because we tend to perceive certain things occur in certain genders, we focus on one rather than the other. The flip side of that is we think insomnia and sleep disturbances are much commoner in men than previously recognised, and that insomnia is not just a problem of worried neurotic women, but is a problem of the entire population and needs to be reflecting that. So our gendered perceptions of how health problems occur is in fact infecting both genders and how well they can do about things. And we really think we need to think about developing better care pathways and better awareness of the differences between genders and the similarities between genders of their problems around their health, particularly as it relates to sleep. Thank you.
Thanks, Bob. So we've dispelled some myths, and Bob's made the point that men are not bad, they're just different, and it's time for the health services to maybe adjust the way that they approach common conditions in men such as sleep. So now you're going to hear from Dr. Shawn Martin, and one of the goals of the Freemasons Foundation Centre for Men's Health is to build capacity in our early career researchers, and Shawn's a great example of that. Dr. Martin is a National Health and Medical Research Council Early Career Fellow in the centre. These are incredibly competitive positions to get. And he's also the project manager for a very large-scale study that we have running called the Florey Adelaide Male Ageing Study. And it's one of the country's most comprehensive and longest-running prospective cohort studies looking at men's health. So, welcome, Shawn.
Thank you, Deb. Could everyone hear me okay? Yep. Thank you, Deb. Thank you, Bob. I cannot but help feel like you've let the Support Act close out the set, but we'll see how we go. So my name's Shawn. As Deb just mentioned, I'm an HMRC Early Career Research Fellow, but I've also spent about a decade in men's health. And along the lines of what Bob was just talking about, we want to spend the next 10 minutes or so talking about a condition that we also feel is undervalued in terms of men's health. So I'm going to be talking a lot about lower urinary tract symptoms, or LUTs, so I should start out by defining what we're talking about here. LUTs is really a range of urological dysfunctions that includes symptoms like an increased frequency or urgency of voiding, increased nighttime voiding or nocturia, incontinence, a weak or intermittent stream, and a straining or a sense of incomplete emptying whilst voiding. More precisely, we tend to refer to these symptoms now in the urological research community, such as it is, as either storage symptoms, so that's a inability for the bladder to properly store urine, or voiding symptoms, that's an inability to properly expel urine. And so just to orientate you in the right direction, when we're talking about the male lower urinary tract, we're talking about this area that includes the bladder here, and the prostate, and then through the urethra. Now, I know we're a couple of minutes away from a comfort break, so that's as explicit as I'll get tonight. So that's what LUTs is. The question, obviously, for us is why are we concerned about LUTs in terms of men and their health services? Well, the first point is that LUTs are very common. Using some of the data that, from the cohort that Bob referred to, we're able to demonstrate that for men over the age of 35, at least a quarter of those men had LUTs. And traditionally, LUTs was very much viewed as a disease that affected primarily older men. We were able to demonstrate that in our young guys, so these are guys aged 35 to 44, and I've just kicked into that demographic, so I'm sticking with that definition of young men. Still about 12% of those guys experience LUTs. So this is something that occurs across the age spectrum. And also LUTs can have a very severe impact on overall health-related quality of life. A few years ago now, about 10 years ago, some colleagues of ours over in Boston combined their data sets with a mega cohort across Europe, and they were able to demonstrate that the effect of LUTs was equivalent or greater to a chronic disease like cardiovascular disease and cancer. That's obviously a statement that often raises a few eyebrows, so I'll just show you the particular paper that came from. Where are we here? So I won't drag you through all the relevant tables, but you can see here that the authors themselves concluded that having moderate symptoms had a similar effect on quality of life as diabetes, hypertension, and cancer, and that those with severe symptoms had a similar effect as having a heart attack or stroke. Now, I've been lucky enough over the past few years to sit in with patient consults with some of our urological colleagues, and I see that's indeed the case. A lot of men stage their whole life around their urological function, so they will only drive as far as they can maintain being dry. Likewise, they'll only go attend a party for however long they can remain dry. This limits also their ability to return to work, etc. This is a set of symptoms that can have a tremendous impact on a man's quality of life. As well, and as Bob alluded to before too, LUTs is a condition that has a significant personal and society-wide economic costs. So Deloitte published some economic modelling a few years ago now that demonstrated that for every individual with incontinence, and this is just looking at incontinence, there's around about a $9,000 cost annually. When you look at society at large, there's almost a $43 billion expenditure on incontinence in Australia. Most of these costs are through indirect measures, what the economists will call deadweight measures. There was only, as you can see here, about $271 million of that expenditure was directly through the primary healthcare system. And that's, we think, a kind of economic argument for re-engaging men with the primary healthcare system around LUTs. One of the important contributions that our group's been able to make is to demonstrate that the risk factors for these conditions are indeed modifiable, that given the right sort of medical treatment, often men will respond to their LUTs and also other health conditions as well. So to demonstrate this point, we've kind of broken down one of our recent LUTS models. I'm sure you're all familiar with pie charts, but in this particular instance, the size of the pie corresponds to the effect size that we're able to demonstrate in our models. So there's a couple of points to make here. First of all, that far from LUTS being a problem that's merely associated with age, you can see there's a variety of biological, psychological, and socio-demographic factors that we're able to demonstrate were associated with LUTS. But when it came to age, you can see here this little piece of the pie. We're only able to demonstrate an effect in relation to avoiding LUTS, and that was only for a very small proportion. The other point is you can see those other effects. So these are things like smoking, sleep apnea, lipids, etc. These are the modifiable risk factors. So these are the ones that are amenable to clinical intervention. And for both storage and avoiding LUTS, the majority of the risk that we were able to detect was a function of these modifiable risk factors. Another contribution that we've been able to make to the literature is to demonstrate that there is a lot of these risk factors are shared with other types of chronic conditions, so things like cardiovascular disease, type 2 diabetes, and depression. Those conditions alone account for the top 3 of the leading 5 causes of disease burden in men in Australia, so they're very important. And what we've been able to demonstrate, and I won't sort of wade through the details too much here, but essentially under the right conditions, LUTS tends to appear upstream of conditions like heart disease and urinary function. In fact, our data showed that on average for men who both had LUTS and then cardiovascular disease, these conditions were about 8.3 years, I think. LUTS occurred about 8.3 years earlier. So this is, as we refer to it, perhaps a canary in the coal mine for some potentially fatal diseases. So that's, I guess, some of the prima facie evidence for why we think we should consider LUTS in primary care. The question is, I guess, how is LUTS treated in primary care? An important part of this story is it was only recently, up until recently, at around about the late 90s, that GPs started to take care of a lot of these patients. Prior to that, anyone with a urological type of condition generally got seen by a urologist. Generally, you had surgery for your severe symptoms. But as I say, with these frontline medications available, now there's a huge proportion of these men that are then being treated by their GPs. Unfortunately, though, there's not great data available on how frequently this occurs. About the best example we have is from the Beach database, the now unfortunately defunded Beach database. And these researchers took around about 200,000 GP encounters for about 2,000 GPs, and they were able to list all the top, most frequent health conditions. So you might not be able to see here, but the top 3, for instance, are things like elevated blood pressure, vaccinations, and chest colds. And again, the top 15 conditions accounted for around about 1/3 of all GP interactions. The next 15 accounted for an additional 20-odd%, so around about half all up. And you had to scroll all the way down to position number 132 before you would see where LUTS was being treated, or the frequency with which LUTS was being treated. And we think this is a problem, obviously. It's a very high prevalence condition. It has a high personal and economic burden, and yet it's not being viewed enough in the GP office. We think that's obviously a combination of efforts that need to be raised by GPs and the patient as well. As I alluded to beforehand, men were actually quite willing to address their lifestyle factors, particularly in relation to LUTS. So there is this kind of almost immediate connection between a change in lifestyle behaviour and your LUTS outcome. And this often isn't the case, say in cardiovascular disease, for instance, where there is quite often if you change your lifestyle behaviour, then obviously there's not that immediate connection with CVD risk. And unfortunately for a lot of the men, they don't observe these CVD symptoms until it's unfortunately too late. So we think there's another reason to keep working in this LUTS field. As I alluded to before, we don't have great data on the management of LUTs by GPs. There was a nice study that was published a few years ago that demonstrated there's actually a bit of a disconnect between what the peak urological conferences advise on how LUTs should be treated and how they're being treated in the GP clinic. So there's, again, no comparable data available in Australia, although we're meeting with we're having GSK get a group of GPs to meet later in the year, and we're going to take steps to address that gap. So I'll wrap up now. I could talk about LUTs and healthcare for hours, and I think that's why I don't get to a lot of dinner parties these days. But just to sort of summarise what I was talking about, we think it's a fair point that there is now an emerging consensus that the healthcare system is not adequately suited to cater to the individual needs and behaviours of men. LUTs appears to be one of these sentinel markers, so this canary in the coal mine, along with other conditions, ED and sleep, as Bob mentioned. And we think that's largely overlooked at this stage by both patient and provider alike. And we think that, again, as Bob sort of suggested, rather than re-engineering the entire healthcare system for men, we think it's a matter of getting better data or using the existing data we have combined with these innate behaviours of men in order to sort of engage their use of the healthcare system. So with that, I'd just like to finish up by thanking my colleagues, particularly our study participants and our volunteers, some of who I know are here today. Our funders, particularly the Freemason Foundation, as Professor Bird alluded to. This is now our 10th year of operation, and we hope to enjoy a continuing association with them, and also the Research Tuesday team who put this together. That's it. Thank you.
Thanks, Shawn. Now, I'm going to invite our speakers to join me up the front for a panel. And I am going to, before I invite questions from you, I've got two questions for the panel. And the first one is about the sleep coach, Bob. Yeah. So I've decided I need a sleep coach. And chances are the sleep coach is going to tell me not to use sleeping medication. And they're going to encourage me to have some cognitive behaviour therapy. So I want you to think about, what would be your advice to someone who has some sleeping problems and is looking for, a way to address them?
You probably don't need a sleep coach on your dime. I'm sure he's expensive. Sleep is, there's a number of issues around sleep, and I suppose it's important to recognise that a clinical sleep condition is qualitatively different from difficulty sleeping and getting inadequate sleep. Having said that, it's probably reasonable if someone is having problems getting off to sleep and feels they're not getting enough sleep, that they can start to think about the ways to improve their sleep habits, what we call sleep hygiene. And recognising that sleep is a habit and can take a while to get into a bad sleep habit and can take a while to get back into a good one. But we think about the notion of sleep health, which refers to getting enough sleep in terms of time, getting sleep at the time when your body wants to be asleep. So pretty much every cell in the body, and certainly every organ and organ system in the body, runs on a body clock. And modern society likes to run its sleep and many of its functions against natural body clocks, and that causes a lot of problems. So the issue of when you have to sleep, and the quality of that sleep becomes important. Thinking about all those things, what do you need to do? In the evening, don't eat. And in fact, there's good data, better data in mice than humans perhaps, that the best way to lose weight is in fact don't snack after your evening meal. So don't eat, don't expose yourself to the sorts of things that wind you up rather than wind you down. And that's usually things related to the internet and screens in the modern world. So spending time on your screen just before you go to bed, spending time on screens in bed is ill-advised, both from the fact that the content of what's on the screen tends to get you up, and the blue light from the screen tends to affect your light perception and tends to affect your sleep. Don't stimulate, the rest of your physiological system with caffeine or other things that tend to ramp yourself up. Get the environment in the bed right, so make it comfortable, not too hot, not too cold, not too noisy, and all those sorts of things. People love their pets, but people who sleep with their pets tend to sleep badly. People who sleep with their partners may or may not sleep badly, but that's a separate issue. Do it at the same time, and probably most importantly, get up at the same time. Light in the morning sets your body clock, so expose yourself to light in the morning. Having said that, there's a lot of apps available to kind of help you through that. Some of them are better than others. At last count, there was, I think at the last meeting I heard 1,322 apps devoted to insomnia. 6 or 10 of those probably have evidence behind them. And if you're interested, we can help you with those. And if all of that doesn't work, then your sleep problems are common. You might need to talk to somebody about that.
Thank you. Sounds pretty straightforward. So we've got a roving mic somewhere. If anyone's got any questions, please feel free to raise your hands. And while we're getting that started, a question for Shawn. LUTS sounds really horrible to me.
Yeah.
It sounds like it can significantly affect your quality of life. Could really restrict, what you could do.
Sure.
Make you feel pretty miserable, both psychologically, cognitively, emotionally.
Yep.
So here's the thing. If someone loses weight and makes some simple lifestyle changes, what's the chance that they can reduce the symptoms that they're suffering from?
Yeah, absolutely. There's a very, very good chance. We're doing an analysis at the moment that shows that particularly for those moderate type symptoms, so LUTS is generally graded as mild, moderate and severe. So the severe symptoms tend to still be referred on to a urologist for surgical treatment. But our analysis is sort of showing, particularly for those moderate type symptoms, that weight loss, particularly losing that abdominal fat mass, that belly fat mass, can be highly effective. And LUTS sort of tends to generally always inevitably increase in severity. So it's important to capture it at that moderate stage, and the lifestyle adaptations are the best longer term bet for reducing your LUTS. There are also sort of acute things you can do, so you can change your fluid intake prior to bed, so not having sort of so many cups of tea just as you can just before you head off to bed. There are bladder training things that a lot of the Continence Foundation has a website where you can go through those standard sort of things. But it's certainly true that even in the case of severe LUTS and either surgical or medical treatment, even if you have those additional lifestyle changes, they can improve the efficacy of the treatment that you receive. So it's sort of important all around, and as I was alluding to before, there's a good connection. You literally often have a pretty quick symptomatic response, so you're able to monitor that you don't go to the toilet as much, or that you don't have some of those stream issues. So there's a good feedback that men in particular seem to really kind of respond to.
Okay.
So
Thank
yeah,
you.
it's a good bet.
Thank you. Okay, and you, Bob, you made it clear to the audience that there are certain things that men are looking for in their consultations. They've got to be businesslike, they've got to be frank. Humour can help if it's appropriate. These are the things that the doctor can do, the physician or the primary care doctor can do. How can men approach their consultations in a way where they get the best bang for their buck? So they're going in for a limited period of time. They want to maximise the return from them. How should they approach the doctor? Do you like people coming to you with a list of questions? fully prepared? Do you like them to come with their partner? You know, what works best, do you reckon?
Planning helps in most things,
Okay.
I think. I suppose the corollary of that, as you're saying, is if you want a business-like outcome and you're focused on a solution, then you probably do need to have an idea about how you're going to get there.
Mm-hmm.
And so having planned that process through is a good idea. So what you want addressed, how you want it addressed, the questions you want addressed, and what you want to get out of that needs to be thought through beforehand. Because if you expect the doctor to mind read everything, then you're probably going to be disappointed.
Yep.
Having said that, you know, the doctor needs to be aware of the fact that you probably do want direct questions about things. And, you know, as we talked about in some of the things that Shawn mentioned and I mentioned, there are a bunch of issues that you can raise that may not get raised otherwise, you know, from our point of view, that may help get you on to some important things. So both sides of the consultation need to be aware of where they're trying to get to. So if you're the patient, I think, yeah, a list of where I want to go to might seem a little bit brusque and abrupt, but isn't a bad thing if that's where you want to head.
Yeah.
The partner depends a bit on what the problem is, I suppose.
Yeah.
Some things are clearly going to be important, you know. Nocturia, erectile dysfunction, even sleep problems are often very usefully discussed with a partner because you get a lot of information you might not get otherwise. You know, abdominal pain or may not be quite so crucial.
Okay. Okay, and you mentioned staying away from electronic devices, particularly if you're trying to regularise your sleep. But do you ever advise any of your patients to maybe use apps for improving lifestyle, maybe enhancing physical activity, making healthy choices? You know, from your perspective as a physician, would you recommend them to men in particular?
I think you need to individualise that. You know, the engineers in the room will often come in with their sort of printout of what they've done over the last 6 months. That can be helpful. And sometimes not. It depends on the person. And I suppose on average, if you're doing a distribution curve, more men might be interested in having an app with a feedback, with a goal, with data that directs them in a certain direction than perhaps on average women. But, you know, there's going to be differences around that. So it probably is depending upon knowing your patient and knowing the person and discussing that with them. I mean, if you want to do more exercise and you know, and you have no idea how many steps you take in a day, then having some instrument that reflects that back to you is very useful. It's a starting point. And you can have a conversation around those sorts of things.
Yeah, right.
Similarly, if you have no idea how long you actually sleep, there may be something good about finding out about how you do that.
Right. Because you might be actually sleeping more than you think, for example.
A lot of people tend to think they sleep a short amount of time and tend to over-report it. People who sleep short amount of hours and are accurate tend to be accurate about that, but there's a substantial proportion of the population, males and females, who will say, oh, I sleep nothing, but actually sleep further than that. And that's a perception thing about you wake up for 5 minutes, you think you've been up for 5 hours. But again, having data around that can be very useful in directing the conversation and perhaps allaying some fears. Oftentimes sleep problems, people get very anxious about their sleep and are worried that I'm not getting enough sleep and it's going to be the end of the world and I'm very concerned about it. And it can be very effective to allay those fears by, you know, having some objective data to suggest probably not as bad as things seem.
Okay. Any questions from the audience? Down here, gentleman down here, thank you. I'll get you the mic.
I'll go here. Just got one here at the top.
Okay. We'll take one at the back and then we'll come to you. Thank you.
Hello, so my name's Jess. I'm a healthy worker advisor with Civil Contractors Federation. So I work in health promotion in the workforce with a male-dominated industry being construction. I'd like to thank you both because you've raised two areas of health that I don't necessarily always focus on. I mainly work with smoking, nutrition, alcohol, physical activity. But I think what you've raised, and especially the call of the canary in the coal mine, has made me really think about the areas. But I'd also like to hear what you think of how I may be able to address areas that are often considered sensitive, being sleep and also urinary areas. How you might address that in a workforce environment, or would you not go there?
Yeah, I get all the fun ones. I get LUTs and erectile dysfunction too. But as Bob alluded to before, generally, our research within our own cohort suggests that you do it with a sense of humour, but you also do it directly. So I know that out of a lot of work we've done, we have certain trigger questions that we can get to GPs and whatever else. So it's for instance, like it's how's your water works? Just a very direct question that starts a conversation immediately about that. I mean, again, Gary, we're here and not sort of flying over the Pacific at the moment. He often talked about, you have these dam-busting questions that once you ask it in a certain way, then you kind of almost can't stop them divulging information. But it's a matter of how you kind of frame it initially. So a direct approach always works, for ED, those type of things. It's just how things going below the belt, etc. Guys will often sort of know what you're talking about. Often I read it referred to as a door handle problem. So guys will head into a consultation knowing that they want to talk about it. And then just, and one more thing, doc, as they're leaving or whoever they need to be speaking to it about. So they're acutely conscious it is an issue. There's just a sense of innate embarrassment, so they don't like to bring it up. So if it's your job to sort of bring those sorts of things up, then the literature suggests just being direct and also doing it with a cheeky smile.
The other thing about them as problems is that they can be a little less moralistic. The problem with talking about smoking, diet, nutrition and everything is it ends up being almost nagging. You need to do things and you're doing the wrong thing, you need to do better, you're a bad person. I'm a respiratory physician, I do smoking all the time, and avoiding the stigma around that is actually really difficult whilst trying to get someone, persuade someone to stop smoking. So other problems like sleep or urinary tract infections or erectile dysfunction can be introduced in a funny way, and you're not suddenly, nagging someone or putting upon them. You're talking about something that is important, but doesn't quite have the pejorative aspect to it. So it can be a useful way to get into a conversation around lifestyle that can then lead to diet, nutrition and smoking and alcohol and whatever as well.
Thank you. And down here, Saskia, the gentleman in the brown coat.
Yeah, I'm late 70s and I get tinnitus in the morning and at night, and it seems to go when I go on my walk in the morning, it vanishes. How common is it, and how can it be fixed?
It's not unbelievably common, but it's common enough, and it's really difficult to treat. And clearly, sort of the white noise, substituting one noise for another thing seems to be one approach people have used, but it can be difficult. I'm not sure I've got an easy answer to that question, especially just in the here and now.
Okay, question up the back. Yep,
Could I have a question as well?
Yep, here, and then
Thank
up
you.
the back, and then there's two over here. Thank you. Gentleman up here.
I probably wasn't paying directed intention, but do you suggest that you should really set a time to go to sleep and a time to actually get up?
The answer to that, by and large, is yes. Certainly a time to get up is very important, because the way you set your body clock is by when you expose yourself to light. So sleeping in long periods of time tends to upset your body clock, and that makes it more difficult to sleep, and also causes dysregulation to a lot of other body systems, even your gut and your metabolic system and your heart system and everything. So the most important bit is getting up at the same time. Going to sleep is usually best at about the same time, but late nights and other things tend to get in the way. The difficulty is, and particularly in the sort of working society, 24/7 society we've got at the moment, people tend to restrict their sleep during the week and then want to sleep in on the weekend. And we know that doesn't substitute completely, and that people who do that tend to have problems with weight, insulin, metabolic problems, diabetes, cognitive function, irritability. There's a long list of problems that go on to infinity. or from sleeping in an hour and a half on a Sunday morning. Sorry to say.
Person up the back, thank you.
Hello. I've worked in health promotion for a long time, and one of the programs we worked with in the Northern Territory was the Tune-Up program, which was the best attended stall in a car show in Darwin. But what's behind that is the issue of communication, and this is what is of great concern to me, because the communication skills of health professionals across the board, and GPs in particular, is not well attuned to men, women, Aboriginal, diverse culture, and so that is the area where we need to improve outcomes, because there are plenty of computer programs that can say a GP can go through to identify risk factors, but it's the communication with the individual that's going to get the outcome and the engagement of the individual.
I'd absolutely agree. A couple of points to make in response to that. One, and not just because the Dean's here, I think we genuinely are better at training health professionals, medical students and nurses certainly now than we were when I was a young pup. And it certainly constitutes a much larger proportion of the courses, and the focus on it is much larger than it was when I was a medical student, when it really was, suck it and see and go out and do what you want to do, and it was very personality dependent. The amount of time spent on training students now in those sorts of areas is much greater than it was, and I genuinely think that the junior medical staff that I see these days are much better at it than I was when I was their age, one. Two, I think, in fairness, particularly to primary care, which is where this is focused on, there is an awful lot of pressure in a business sense and also in a general sense to get through consultations. And so, 8 minutes is very, very hard to take a history, examine someone and then talk to them about what you want to do next. And that's a really difficult problem. And the way we have general practice structured in this country is not easily going to be fixed, in the next 5 minutes. And there are ways around that by, not using the most expensive health practitioner, the GP, to deliver much of this communication, and much of it can be done by other people in other ways in other places, and that probably needs to be recognised. And the way people structure their general practice so that if you've got one problem, you focus on that one and get people back for the second one. But again, that costs money and co-pays. And it's not an easy problem. I take your point. I think we need to come up with some more imaginative and clever ways of getting around that. Perhaps one of the ways is not totally reliant upon the 7-minute general practice consultation to achieve all of our health goals, including the communication. And programs such as the stuff you're talking about doing it, may be one way of doing that, taking it out of general practice.
Yeah, and I would just add too, obviously I'm not a clinician, but in my previous role as a project manager for a large cohort study, about 2,500 odd guys, we would very often hear that same sort of level of frustration. We also did some work around men's health that was then taken up by what was then the peak men's health body in Australia, and adapted that for GP guides. And they were very receptive to that information. They just don't have that information. So in that slide I showed you before, there's something like 200 odd health conditions that they have to be across. And obviously they haven't got time to then do a deep dive into the literature and get across all the nuances of every health condition. But they are very receptive to good, valuable information. When you give it to them, it's just as researchers, we need to be more geared towards giving them targeted questions that they can ask their patients, then help break down some of those communication barriers. But they're certainly receptive to it. There's just not a lot of good advice getting through to them, and that's partly our responsibility as researchers, and more than willing to do it. We just need the funding to do it.
Thank you. Questions over here?
Shawn, can I take you back to your pie chart
Sure.
slide? As I saw it, that was a correlation between the storage and the voiding symptoms. In what sense is being widowed a significant correlation? Because the slice of the pie on both charts appeared to be quite significant.
Yeah, that's a fascinating one. That was kind of one that was surprising for us, and it popped up in everything. A lot of health conditions we looked at, so not just LUTs, ED, depression, obviously, those sorts of conditions. So, so far as we can tell, it's a huge effect. It is consistent, and we think that's often related to, particularly for older men, the way that they look after themselves, basically, once they lose their partner. So we see it most prominently in older men. For younger guys who are widowed, it's less a function. There are also physiological reasons, so depending on the condition. So if you take erectile dysfunction, for instance, if you become a widow, there's at least an extended period where your testosterone tends to decline. The evolutionary biologists talk about that being a natural adaptive mechanism, but it's something that we see. It can also respond back to normal over time. So it's kind of a grab bag for a variety of different issues, psychosocial issues too, obviously. But yeah, it's a Trojan horse for a variety of things, but it's something we can see consistently across the course, and something that within Men's Health we've been trying to focus on. As I alluded to before, we see 2,500 guys, a lot who have unfortunately just recently lost their partner, and we don't seem really good as a society of catching those guys. There are some great programs like Meals on Wheels, those types of programs that can help them adjust to life after their partner, but there's not a lot. So our data at least suggests that that can be a triggering event for a cascade of a variety of health conditions to pop up. So we need to be better at capturing how we look after those guys, particularly with an extended life expectancy where guys can live 20, 30 years after losing their partner initially. So it's a very important issue.
Thank you. There's another one over here. Here, and then we'll come down to you. Thank you. Thank you.
Yeah, I see that you mentioned that ResMed is basically funding some of your very important activities. And I wonder, is there any sense to a degree that you have to manage conflict of interest with this type of basically investment in your work? Because, as I understand it, and I hope I'm correct, is ResMed actually do manufacture CPAP machines for the treatment of sleep apnea, which brings me to a probably second point, that there seems to be in this whole sleep apnea landscape quite a lot of activity by the private industry, the machine manufacturers, rather than the health industry itself. And I wonder if we're all comfortable with this situation.
2 points to make there, I think. One, the funding is actually from the ResMed Foundation, which was actually a competitive grant from the ResMed Foundation in the United States, rather than the ResMed company as a direct subsidy to our research. The notion of activity in the area, I think the sleep industry is in flux, and how we as a community respond to that needs to be thought through. And I think that the issue at the moment really is there are certainly significant external commercial pressures around getting more machines out to the public. We need probably better data around who those machines best are used in. And how we can best identify the people, men and women, for whom they will derive the most benefit. And right at the moment, that's a little bit up in the air. Part of our problem in sleep, especially sleep apnea, is that Colin Sullivan in Sydney found a solution to the problem 30 years ago, perhaps before we had any idea what the problem was, which was wonderful for him and for some people. But we've been scrabbling to catch up ever since in terms of working out who is actually at risk of health problems from sleep apnea, who benefits from the machines, who benefits from interventions, and who benefits from other sorts of interventions. And we are spending a great deal of time trying to sort that out at the moment. We think we've got a reasonably good idea around that, but we still need to do some more work on it. And I suppose I'm, as a practitioner, cautious and wary about delivering all of that over to the manufacturers and the suppliers.
Could I just add another point to that? As you know, a junior researcher, it's part of our role to fill in the conflict of interest statements anytime we publish in a certain area. So we've recently just started to publish in the sleep area for things around nocturia and ED, and for our beloved senior clinical colleagues, it's reams and reams of copy and pasting you have to do in order to fully disclose any potential financial arrangement they might have. I know with that particular work around nocturia and then ED, the money that comes from ResMed, they just give it to you and you never hear from them. So, you know, it's not like there's a hidden hand behind the research. I know from Bob's point of view, that just wouldn't ever happen. So, and also too, more broadly in the university now, we're encouraged as junior researchers to think about translation. So just to not press send on our papers and just let them to disappear into the ether or travel around like Vegas, you know, crooners trying to shop paper from various country to country. So we have to engage with industry, and you know, I feel very comfortable as a junior researcher that there are protective mechanisms to make sure that, you know, you don't have industry knocking on your door and making sure that, you know, you just nudge that figure a little bit to the left. So I think there are a lot of safeguards against that issue that you rightly bring up.
Thank you. Question down the front.
Thank you, gentlemen. My question relates to exercise for older men. And I'd like you to confirm or deny or just comment on that wonderful paper done in Australia on 12,000 men, which found that older men need 150 minutes a week of vigorous exercise in order to achieve healthy ageing. Thank you.
Mike, I'm desperately looking for my colleague, Dr. Camille Short, who's an expert in physical activity. She has recently got me to get a standing desk. So she's been terribly influential. I know the data that you're referring to, that comes from the National Physical Activity Survey. It's not actually 150 minutes of vigorous activity a day, it's 150 minutes of moderate to vigorous activity per day. The way we calculate it from a cohort perspective is that the vigorous activity is double weighted. So if you do 20 minutes of running around the block, that counts as 40 minutes. Moderate activity, defined as just a slight incremental increase in heart rate, only counts for a single weighting. So, you know, if you were to do 75 minutes of vigorous activity, that would probably get you across the line. The NPAS also is very active on encouraging you to do at least some amount of physical activity per day over the weekday, so at least 5 episodes of that.
I think the other important thing to probably recognise around physical activity in anybody is the importance of both resistance training and aerobic activity. Clearly aerobic activity is very important for maintaining cardiovascular function, but in terms of healthy ageing, both in maintaining muscle mass and maintaining strength to do functioning, but also maintaining testosterone levels and improving, you know, metabolic functions like diabetes and other things, strength training or resistance training of some form is as important and potentially possibly even more important than just aerobic training. So the 150 minutes or the 75 minutes ideally would be broken up into some sort of aerobic training, whatever that might be, and some sort of resistance training to maintain strength and muscle mass. And that goes equally for trying to lose weight, where it's important to not just try and eliminate you know, your calories, because you need to keep the protein up in order to maintain the muscle mass. And muscle is very important with ageing.
I know that there are female-oriented health services out there, and I was just wondering your opinion on whether it would be useful to have male-oriented health services and why they're not around at the moment.
Yeah, I've been nominated to take the bullet on this one. I think that's something, or I know that's something that we looked at in the centre. There was some preliminary work we had done across a bunch of guys to see whether or not they would like men's specific health services. So I think by and large there was a degree of interest in that. Interestingly, that was particularly for younger men. They were very interested in having a dedicated men's service. I know more broadly the WHO a couple of years ago brought out a standing paper that suggested that men's has to be part of this global equity push. So men's health has to be part of that global equity push. As someone who was interested in men's health, I was excited about that paper and then just watched as just tumbleweeds occurred. Men's health as a topic isn't really within the zeitgeist. It's not sexy, and there's probably a range of reasons why that's the case. But I think, in principle, it's probably a good suggestion. I think you have to be pragmatic in that in the current kind of funding climate, it's probably more about, as we spoke about before, just maximising the information or the services that we have and figuring out how to better engage men with that. But I don't know, it's probably one for the clinicians. So.
I suppose the other way of approaching that is to ask whether women's health centres have necessarily globally improved women's health in general as distinct from improved certain aspects of it. And I'm not totally convinced that women's health centres have necessarily improved cardiovascular health in women, for instance, where the management of cardiovascular health in women has not necessarily been generally improved by such centres, despite the fact that's the sort of that kills more women than anything else. So the question would need to be, what do you think you're going to get out of a men's health centre that you wouldn't get out of a general health centre that was aware, sensitive to men's concerns? So as a personal belief, I'd be suggesting we probably need to think about how we can improve the health system in general to take note of the differences in gender around health problems, rather than necessarily set up a parallel health system that may not be addressing a whole bunch of issues.
I think we've got time for one more. Yep.
Yeah, just a short background. My name's Mike. I'm doing first year nursing. I've gone back to uni this year, primarily to look for work in men's health. 4 years ago, living in Ballarat, out in Port Lincoln, I'd closed a business here in Goolwa, and I was over 125 kilos. I was diagnosed then with chronic sleep apnea, snoring. I'd stop breathing for over 30 seconds at a time. I'd stop playing sport, and I was almost depressed. But using an app on the phone in MyFitnessPal, because there was nothing out there for men, I started going to the gym, started doing running and walking. I lost over 30 kilos in 3 years. Now 100 kilos. I want to get lower again. But in that time, I was also going to the toilet 3 times a night. Since I've lost the weight, since I've been on a CPAP machine, and it's changed my life like you wouldn't believe, I don't go to the toilet at all during the night. I get 6.5 hours, 7 hours sleep. So my question is, have you done any research linking those two together? I mean, obviously there's the weight loss, but there's also the sleep pattern, getting a good 6.5, 7 hours sleep, and not having to get up and go to the toilet again.
Yes. In fact, by the sound of you, we need to get you on an ad. You're a poster boy for what we're saying. Nocturia, going to sleep at night, is a common symptom of sleep apnea, we think. And there's some good physiological reasons for that that I won't go into, but there's reasons why that might be the case. And as a clinician, I can certainly cure quite a lot of nocturia by managing people's sleep apnea, be that with a machine or be that by weight loss. So both of them are very effective at managing that sort of problem. So that's not an uncommon story. Perhaps not quite as successful as, as your story, which is very good, but two of them are definitely linked. There's good physiological reasons for that to be happening, and there's good reasons why fixing the problem can lead to that, and why, you know, some people who say, oh, I've got prostate problems, don't have prostate problems, they have problems with other things, and that is important to go through before you start sending people off for prostate surgery. Not to say people who don't have prostate problems don't have prostate surgery, but it's important to consider all the other issues that might be involved. So yeah, thanks for your story. I'm happy to agree with you.
I think we've got time for one last one. Okay, over here, thank you.
I wonder, could you expand on care pathways? I'm familiar with Liverpool care and similar pathways, but if you could expand on this in relation to sleep apnea or sleep disorders, I would appreciate that.
If a remarkably large percentage of the population that we found in our studies have a sleep problem, the rationale is that the specialist services will not be able to manage that huge community burden of sleep. So that we need to better define what can be managed in primary care, what can be managed in fact in care, you know, nursing practitioners, non-medical practitioner care, what can then be assisted by recourse to referring people to things like apps that help people with sleep quality, sleep habits, sleep hygiene, what might be benefit from things like improving diet, nutrition, exercise, sleep quality, losing weight, and what might require referral onto simple models of managing sleep apnea. We do a lot of work with colleagues at what was the REPAT and now be at Flinders at AISH, who have demonstrated, you know, nurse-led models of managing sleep apnea are very effective for uncomplicated, simple sleep apnea. Similarly, you know, simple models of cognitive behavioural therapy that can be run off apps or web-based or, you know, by general practitioners, leading up to other people who clearly need specialist intervention, who have complex problems with sleep apnea with comorbidities, insomnia that's difficult to manage. At the moment, we don't really have any of that defined as a pathway. It happens ad hoc. If you're lucky, you get certain things done. If you're not, you're not. And we need to try and make that as effective and efficient as managing coronary artery disease, lung cancer, prostate cancer, breast cancer, any of those number of things where there are very clear ways of managing X to Y in the community and people get the outcomes that they deserve. We don't have that for sleep as a broad thing at the moment, and we're trying to start from now to get that worked out.
Thanks, Bob. So before I flick back to Alistair to formally thank you for coming out tonight, if any of you are interested in participating in any of our research projects, we've got a large register where people can put their names forward to be considered for studies that they might be eligible for. This is a really important aspect of our work, and it's a way of making sure that we stay connected with the community. So I'll hand you now back to Alistair, who will thank you for coming.
Thank you very much. So sadly we are out of time now, and it's my pleasure to thank the team for their great presentations. I think these are always great events, but tonight was a very special event, so thank you to Bob, Shawn and Deb. Thank you also for your attendance, your participation, great comments, great questions, and it's added very much to the richness of tonight's event. The Research Tuesdays will be back on the 12th of September with a very special event. That is our 3-minute thesis finals. For those of you who have not been to that before, that's where we get our very best higher degree research students to present their research in just 3 minutes and with just one PowerPoint slide, and it's always a fantastic evening. Please note that that meeting will not be here, but it'll be down in the new Adelaide Health and Medical Sciences building, which I'm always delighted to show off, and that's down beside Samry and the new Royal Adelaide, which will be open by then. So thank you all again for attending, and good night and safe home. Thank you.